So I'd like to echo what a lot of the other speakers have said already and thank Alexandra and the JSCAI board for really a significant contribution to moving forward research in the space of calcific coronary artery disease and also in the wider space of complex coronary disease, which is my main focus of my clinical work and my research work. And I'd like to just highlight, I think, some of the key papers over the last few years which have really moved the thinking in the field forward, and JSCAI has been very prominent in that. So the first paper I want to draw your attention to, and most of you have probably seen this already, but if you haven't, I would really strongly counsel you to read it. This was the SCAI expert consensus on the management of calcified coronary disease, led by Rob Riley and Benita Shah. And not only when it was published in January last year, has it got a very comprehensive coverage of all the research until that time point, but it also gives a really kind of fantastic collection of lists of tips and tricks on how to use all the different technologies. And as we went through this process of coming up with a consensus, even 15 years into practice in this space, I learned things from my colleagues as we went back and forward with how we do certain things. So I think it's a really great read. And within it, we also, with Keiko Mahara, came up with this pretty simplified summary of how to assess for severe calcium, both angiographically and with imaging, and then came up with this consensus algorithm that you'll have seen probably a few times during the course of the last 24 hours if you've been at any of the complex PCI sessions. But basically, I think of all the calcium algorithms, and I've been involved in a few of these, this is the most pragmatic and easiest to use. I think it's pretty simple. So essentially, you look at all the criteria for calcium severity as illustrated on the previous slide and summarised in that box on the left. It advises you to try and image early on in the case and then to use the imaging criteria to confirm you've got severe calcium and then to go on and select the appropriate device. It obviously further guides you through the fact that if you can't image, you should try and cross with a balloon, and if it's uncrossable, you're going to do atherectomy. One of the things I like about this algorithm, rather than being didactic about this, use this device, this, use this device, it suggests that in certain morphologies and situations, one device might be preferable over another, but it's not completely didactic, and that's consistent with real-world practice in the cath lab. At the same time, in January last year, was also this really interesting publication from Bobby Ye's group looking at the NCDR PCI registry. So what they did was they looked at the use of calcium modification devices during PCI after the introduction of IVL, and what they found was really quite significant. And again, I think in our cath labs we've seen this change. So on the far left, that's 2018. And what you see in the bars there, the yellow bars are atherectomy, and the blue bars are different types of scoring and cutting balloons, and the little blue bar in the middle is combination therapy. And you see really from 2018 through to 2020, there's a kind of slightly slow rise in calcium modification from about 9% up to about 10–11%. And then IVL becomes commercially available, and you see calcium modification use goes up to 16%, and within really 1 year, IVL dominates the market, so used in 6% of cases, more than any other device available for calcium modification. And when you look at actually the trend for each of the individual technologies, if the blue and the orange bars there are the atherectomy devices, you see a kind of slow rise to a peak, and then suddenly IVL comes on the yellow line, and there's an exponential rise, and then a kind of steady fall in the atherectomy devices reflecting that. So really kind of interesting. And the last thing in that paper I thought is quite interesting is this is variation in use of calcium modification across different sites in the registry. So some sites using none of these technologies, and some sites using them in 60% of their cases, which, to me is somewhat, surprising. Even working in a quaternary centre where we get referral on cases, that seems pretty high to me. They went on in the analysis to do a multivariate analysis to look at predictors of whether you got calcium modification, and this kind of leads me on to the rest of this talk. So what you see in the top table is predictors of any form of calcium modification, and you see that for 10-year increments, as you would expect, you're more likely to get calcium modification as you get older. But also interestingly, if you're female, you are less likely to get calcium modification, and also for for some of the race groups you can see there in the table. And if you go to the second table, this is specifically use of IVL in 2022. So you see that you were more likely to get IVL if you were older, less likely if you were a woman or in any of the racial minorities, right? So this kind of highlights that there is variability in access to these technologies in different patient subsets. So shifting focus onto the area of sex-specific therapy and outcomes, I want to backtrack a couple of years to January 2022, and this was an analysis, a patient-level analysis from the Disrupt CAD studies led by Alexandra, looking at the different outcomes and sexes with the use of IVL in those trials. And one important thing to point out here that becomes relevant as we go on is that you'll see that only 144 of the overall population were women, 484 were men. So like most of the cardiovascular trials we discuss, around about 20% of the study population is women. And you'll see in the top right-hand corner that reassuringly, when you compare women to men, IVL is efficacious in women as in men, so looking at procedural success. If we look in the bottom, you'll see that procedural complications were no higher in women than in men. In fact, numerically, they were higher in men. And that's important because there's been multiple large registries published on atherectomy that shows that atherectomy is higher risk in women. Women have more complications after atherectomy. And not only just procedural complications, but when you follow them up, they have higher MACE and other clinical events during follow-up. And you see in the top left here that with IVL, there was no difference in the clinical event rates between men and women. So interestingly, a technology now for the first time in calcium in men and women where the efficacy and the safety appears to be the same. In the month following the publication of that, there was the SCAI expert consensus statement on sex-specific considerations and revascularization. And within this, in this segment that focused on calcific disease, the kind of expert consensus opinion was it looked like IVL may emerge as a first-line therapy for plaque modification in calcific lesions in women as a favoured approach. So this stimulated us on, Alexandra and myself, to work with Shockwave to develop the Empower trial. And just to tell you a little bit about that, because the results are imminent. So the Empower CAD study was a prospective multi-centre single-arm observational trial. The target was 400 subjects across 50 sites in the US and Europe. The follow-up is planned 30 days, 1, 2, and 3 years. The study population was basically any female patient who you were going to do PCI and you planned to use IVL. Very importantly, we wanted this to be an all-comer study, so we recognized that the other Disrupt trials, very much a clinical trial type population, we wanted this to be a real-world all-comers trial. So the only thing that excluded you in this trial was if you had in-stent restenosis or you had cardiogenic shock. So if you had a left main, multiple lesions, CTOs, you wanted to use other adjunctive devices, you could still be included in the trial. And I'll show you in a second, but we devised this IVL first algorithm with the thinking being that there's a signal that IVL might be the safest approach. Let's devise an algorithm where the female patients are treated with IVL as the first device that you reach for during your case. The primary endpoint is the safety endpoint, target lesion failure at 30 days. So target vessel MI, ischemia-driven TLR and cardiac death, and then the efficacy endpoint, procedural success, and there's an OCT sub-study. So this was the algorithm. So essentially, you confirm that you've got severe calcium, you take the IVL out to treat it. If the IVL passes, great, you proceed on and complete your case. But we wanted to make it real world, so we didn't want to exclude patients where the IVL wouldn't cross. So if you couldn't deliver the IVL, you could then reach for atherectomy or any other device to pre-treat the lesion and then go back to your IVL after that if you felt it was needed. If you used the IVL and you felt it wasn't adequate, you could then go on and use another device if necessary. So really to test a strategy of how this would work in women. So we completed enrollment in the trial in October, ended up being 48 sites, 2/3 in the US, 1/3 in Europe. Actually, it was 399 patients ultimately. And really remarkably, we managed to finish recruitment 5 months ahead of plans, which I have to say in my career is the first time that's happened to me in a clinical trial. So we're absolutely delighted about that. A few things just to highlight from the study. Firstly, the IVL first strategy, we've been having a look at the data, and actually you were able to use IVL as your first device effectively in over 90% of the cases. And when we get to, when the data comes out, you'll see this was a really highly complex patient population, so very high prevalence of comorbidities and very complex coronary disease with a mean calcium length of 40 millimeters. So even in those types of patients, we were able to use IVL first in 90%. One of the other things we had recognized that before the trial was not only are women underrepresented as patients in trials, but women are underrepresented as investigators in trials and in the leadership roles. So we kind of started off with Shockwave with a plan to try and get 50-50 male and female leadership in the trial and as PIs at the sites, and actually ultimately we ended up with 71%. So we're really delighted, and a lot of them were female interventional cardiologists who have never been PIs for clinical trials before, so we feel that we've kind of opened the door to try and encourage young female interventionalists to get involved in clinical research. So the study design paper was published in JSCAI in October, and we're hoping that the 30-day outcome primary endpoint will be ready for our late-breaking trial session at EuroPCR in a few weeks' time. Thanks.
Thanks so much, Margaret. That was outstanding.